This lesson, we're going to take a look at the gallbladder using point-of-care ultrasound. So as we discussed in our introduction, the gallbladder is an anechoic structure that's normally anterior and inferior to the liver with a smooth contour and thin walls, and has a variety of different ultrasonographic artifacts that can be present, including posterior acoustic enhancement, edge artifact, etc. Let's go over how to perform a biliary exam using point-of-care ultrasound. Our probe of choice is going to be the curvilinear probe, although once again you can utilize the phased array probe if that's what you have available to you. And then for this view, we're generally going to have our patients be supine. There's not much benefit to having them in Trendelenburg or reverse Trendelenburg. However, you may want your patient to lay in the left lateral decubitus position, or to instruct them to pooch out their stomach or have a deep inspiration and try to hold it, as that will sometimes move the liver, diaphragm, and gallbladder more inferiorly and into a better window for you to visualize them, especially if the gallbladder is up behind ribs. So I know there are a lot of words on this slide, but we're going to go over each of these steps one by one so you won't get lost. Before we start about our biliary exam technique, let's review optimizing our image. So remember to have your probe oriented towards the patient's head or to the right side. In this case, we'll probably start in the longitudinal view with the probe indicator pointed towards the patient's head. We'll use the abdomen preset. We'll have our machine set to a moderate gain. Ideally, we've told our patient to be fasting, and if we do happen to encounter any bowel gas, we can use pressure or jiggle maneuver to dislodge that bowel gas and visualize. So we're going to start by placing our probe in the long axis or the longitudinal axis with the probe marker pointed towards the patient's head at the mid-clavicular line just below the costal margin. So you'll palpate your patient, you'll find that inferior costal margin right below the ribs, and place your probe there. And you may or may not see the gallbladder straight away, or you may see bowel gas like I have in this image. If you do happen to see bowel gas, that means we need to translate the probe. Our next steps will involve translating laterally along the costal margin, so sort of in an arc, just following that rib cage down towards the patient's right side until we visualize the gallbladder, which we've already talked about what it looks like. Once we see the gallbladder, it will probably look like an oblong or circular structure because we'll be cutting it at an oblique axis with our ultrasound waves. So once we identify it and sort of get it in the middle of the screen, then we can start to rotate our probe to maximize our image. As we rotate the probe to the long axis, what we're going to be looking for is an exclamation point looking sign. So this is our gallbladder fundus here. Let me find our probe. Our fundus, and we've got the anechoic inside, the viscus of our organ here, and then we have our gallbladder neck and the ducts that lead into the portal triad. And so oftentimes this will take on a sort of exclamation point looking appearance. Every now and then it'll be continuous and you won't have that little break between them, but most of the time there's that flexure between the body of the gallbladder and the ducts, the cystic duct and then the common bile duct. And so I generally instruct my residents to look for this sign because it's pretty easy to recognize. Once we've isolated the gallbladder in the long axis, we do want to go ahead and take a measurement of its length. And so that'll be from the outside to the outside of that longest axis in the longitudinal orientation. Next, you want to rotate your probe to the short axis by just simply rotating the probe 90 degrees. So now that indicator is going to be facing more towards the patient's right side. And once again, you're going to measure the width of the gallbladder. And then this is also where you're going to measure the anterior wall of the gallbladder. And I see an example of that right here. And so this is evaluating for gallbladder wall thickening, which is, of course, one of our signs of acute cholecystitis. And so you do that by placing so zoom in as much as you can, reduce your depth, or use the zoom setting on your machine. And then you're going to place the cursors over the external borders of that hyperechoic gallbladder wall, hyperechoic gallbladder wall. And so right here, we've got one marker, and right here, the other. And we'll talk about what the upper limit is of normal, if you don't remember off the top of your head, on an upcoming slide. After we've taken those measurements, we're going to go ahead and evaluate for other signs of pathology, including stones and sludge, whether or not there's any dilation or pericholecystic fluid, and we'll go over examples of that here in just a couple of minutes. Lastly, we're going to find and measure the common bile duct and measure its diameter. And that can be a little bit challenging, so I've devoted a couple of slides to that here just after this one. So finding the gallbladder and taking those measurements, evaluating for stones and sludge is really not too difficult of an exam. But where this exam gets challenging is trying to isolate and measure the common bile duct. So the common bile duct measurement, we may actually be measuring the cystic or common hepatic duct because there's not a good way oftentimes to visualize each of those individual structures. But if there is a stone, it could be in any one of those locations blocking and causing dilation. And so if you see a duct that you can measure, the closest one to the gallbladder, that's usually where you want to take your measurement. What you'll notice is that when you are in the transverse appearance or the transverse plane of that portal triad, you'll see what we call the Mickey Mouse sign. You can sort of see an example of that here, and there's a better one on the next slide, but we've got our gallbladder, and then we have the portal triad, and you can see actually here's this duct right here that's leading from the gallbladder into the portal triad, and in the transverse appearance, it's going to take the appearance of a Mickey Mouse sign. The normal measurement of the common bile duct should be less than or equal to 6 millimeters, although this will increase based on the patient's age. So if you have a patient that's 70 years old, you can have a measurement that's up to 7 millimeters. Or if they're 80, it can be 8 millimeters. And then in patients who have had a cholecystectomy, this duct will dilate because it will become the primary storage site for bile now that the gallbladder has been removed. And a normal post-operative measurement for the common bile duct is less than or equal to 10 millimeters or 1 centimeter in diameter. I'm going to dive into a little bit more detail on the next slide. So here you can see this classic Mickey Mouse appearance. So we've got our gallbladder, we've got a little fold in the neck, and then we've got the hepatic artery and the common bile duct with the portal vein. I would urge you to use color flow to be able to identify and make sure that you're measuring the common bile duct and not one of these vascular structures. And so I've got an example of that right here. So with this view, you can see that we've got our two flows. You can see flow in this vessel here. You see the gallbladder, and this portal vein is lighting up. And that's how you can really be sure that you're taking a measurement of the common bile duct. There should be no flow because the flow through this structure is so low that it's not going to be picked up on color Doppler. And so the adequate image for measuring this would be a still image with color flow in place, proving that there is no flow in the common bile duct. And our measurement for this is going to be from the inside border to the inside border of those hyperechoic walls of the common bile duct. So that is how you do it. It takes a ton of practice. This is still something that can be challenging even for very experienced ultrasonographers, and you may not get it on every patient, but it is something that I want you to try to get every time that you're doing a right upper quadrant ultrasound. Let's go ahead and take a look at what some abnormal biliary findings might look like. And we'll start by looking at gallbladder stones, polyps, and sludge. So stones, polyps, and sludge in the gallbladder are all intraluminal findings, meaning we see them inside the body of the gallbladder, and it disrupts the normal anechoic appearance of the gallbladder. So stones will be echogenic. They will typically be mobile, meaning if you reposition your patient, they should sort of fall to the most dependent portion, although every now and then they won't. So it's not, you don't have to see that they are mobile, but generally that can be a clue if you're trying to differentiate between a polyp and a stone, because polyps will be fixed. They generally have an irregular appearance and they will cast acoustic shadows. So here in this image, we can see that there is a collection of hyperechoic findings down here representing some stones. And we see posterior acoustic shadowing, and they are in a dependent location in this supine patient. And so these are gallstones. And they are in the sort of the neck of the gallbladder right there as it approaches the portal triad. Meanwhile, polyps will not always be located at the neck, although they certainly can be. But a differentiating factor here is although they may be hyperechoic and echogenic, they usually will not cast a shadow. And so here they're affixed to the wall, it's not falling down in the most dependent position, and we're not seeing a shadow deep to it. And so this is a sign of a gallbladder polyp. And then lastly, you can also see sludge inside the gallbladder, which is a layering hyperechoic debris, usually that will not cast a shadow. In fact, sometimes you may get posterior acoustic enhancement. And so in this patient, we see our gallbladder here in the short axis. We see this sort of layer that looks like a slightly brighter collection. If you move them around, it might kind of slurp and slurp around the sides of the gallbladder. And this represents gallbladder sludge, which can certainly be present in acute cholecystitis. So speaking of acute cholecystitis, let's go ahead and take a look at the ultrasonographic findings that are diagnostic for this condition. So starting off, the first finding that is going to be helpful for making this diagnosis is cholelithiasis, or the presence of gallbladder stones. And specifically, we like to see these stones at the neck of the gallbladder because that implies that they could be constricting the obstruction of the flow of the bile and leading to obstruction that obviously can get infected and cause acute cholecystitis. So here we see a stone, we see posterior acoustic shadowing, and then we also start to see that the walls of this gallbladder are starting to look a little bit thicker, which is another one of our findings, but I'll show you that on another slide. So first up, we've got cholelithiasis. That's one of our findings. The next finding is a positive sonographic Murphy's sign, which means with our probe, as we push in and try to compress the gallbladder, which you can see here, a patient will say, "Ouch, that hurts," or they will scream and punch you in the face. Whatever it is that they need to do to express themselves in that moment, we want to be patient-centered physicians. But a positive sonographic Murphy sign is more sensitive than just a regular Murphy sign with our physical exam for identifying bladder or gallbladder pathology. The next finding is pericholecystic fluid. So pericholecystic fluid refers to fluid that is surrounding the walls of the gallbladder. And I've gone back to our original image here because actually this is a good example of that. This can be very, very subtle. And so you really have to kind of pay attention on your exam to visualize this. But if you notice around this gallbladder here, we can almost see what looks like a train track appearance. Like there's a bright white line here representing the wall, and there's another one here that's actually the wall of the liver. And then in between, there's this really thin kind of sliver of anechoic fluid that has built up in between these two structures and represents edema and then eventual leakage of fluid from the gallbladder wall. And so that is what pericholecystic fluid will look like on ultrasound. And it can be more dramatic than this, but most commonly when I've seen it, it's pretty subtle. And so I wanted to choose a subtle example for you. There's another example right down here of some pericholecystic fluid surrounding this gallbladder. And then lastly, we've got gallbladder wall thickening. And so if we took a measurement and we took, a measurement from about there to there, we can see just based on our scale that we're approaching, maybe 6, 7 millimeters, 8 millimeters, and anything that's more than 4 millimeters is going to be positive for gallbladder wall thickening. Now we know that gallstones can not only get stuck inside the gallbladder, but can actually progress into the common bile duct and eventually downstream and result in common bile duct dilation. So let's take a look at what that might look like on ultrasound. So as the common bile duct starts to dilate, once again, we're going to need to get color Doppler views of this structure. And in this view, we can actually see that we've got a stone here that we can visualize inside the common bile duct, and then there's some posterior acoustic shadowing that we can see deep to that. And so we've got our color flow on, we've got our portal triad here, and then this is a very dilated common bile duct that is pretty angry, and we can take this measurement. Now, if you're having trouble visualizing the common bile duct, let me put on our Mickey Mouse sign here. So there's our Mickey Mouse sign. I'm going to go ahead and remove it. So we've got our portal vein, we've got our hepatic artery, and then we've got our common bile duct right there. So that measurement from the inside wall to the inside wall is what we would take. In this case is often or is very clearly positive for a dilated common bile duct. So isolated ductal dilation can be caused by a current stone in this case, or a recent stone that has passed, but there are some other things that can cause common bile duct dilation. So remember our pancreatic pathologies, so tumors of the pancreatic head can certainly cause external compression. Physiologic dilation or post-surgical dilation can also occur that can be physiologic and non-pathological. But it's more common to not see a stone than to see one. So although I chose an image here with a stone to clearly visualize it, remember more commonly we'll just see this duct dilated and is not currently present. If a stone is seen, though, we do need to consider the diagnosis of cholecystitis or choledocholithiasis or ascending cholangitis. And so these are cases that we'll often need to order MRCPs on and consult our surgical or GI colleagues to help us with our diagnostics and therapeutic management. So another artifact that's important to note is the twinkling artifact. This is well associated with urinary stones, so your kidney stones and stones that have been lodged in the bladder, and we'll take a look at that in a later lesson. However, we can also utilize it to visualize small stones that may or may not have prominent shadowing. So I've taken these examples here with and without color flow. And so on this left-hand side, we can see a tiny little stone here with a little bit of shadowing. But you can imagine that if this was a study with less resolution or that wasn't quite as big of a stone, that would be pretty difficult to visualize. What we can do is putting on color flow, because this is a super reflective structure that results in diminishment of the waves returning beneath it, we actually get what looks like a bright twinkling artifact with color going in both directions. So we get both reds and blues and yellows that happen right over those stones, and that's because of the highly reflective nature of stones. And so a twinkling artifact, while it's, like I said, more associated with urinary stones, has been increasingly recognized as something that can be seen with gallbladder stones as well, and can be helpful if you're kind of equivocal about whether or not you see a stone present. So that twinkling artifact can be helpful. Let's take a look at some other things you may see when you're taking a look at the gallbladder with ultrasound. So I mentioned that edge artifact or edge shadow artifact can be present with the gallbladder, and that's due to the curved structure of the gallbladder. And so these echogenic curved gallbladder walls will refract some of those ultrasound waves off to the sides, and then you'll get decreased signal return from those ultrasound waves deep to those edges. And so this can be mistaken for stones. And so that's a a thing that you need to remember when you're looking at any sort of curved structure is that if you're seeing an edge artifact, you may need to change the angle of inclination and tilt your probe off to the side. And you'll notice that once you tilted this probe, that this edge artifact maybe swings over to a different direction or completely goes away. And that can help you differentiate between edge artifact versus a stone or polyp. Another finding that's unique to the gallbladder is the wall echo shadow sign, or WES sign. And what happens here is that the gallbladder has basically been completely filled with stones or has contracted in an effort to kind of pump those stones through the duct and get rid of them. And what happens is you basically will get rid of the anechoic findings of the gallbladder. And so here we can see a liver tip and we have a kidney. There's a rib shadow that's sort of getting in the way. But if you focus right in this area, you see this anechoic structure where we would expect to see a gallbladder. There's no anechoic structure there. In fact, it's a hyperechoic structure representing the wall and then the stones with the posterior acoustic shadowing happening. And so this gallbladder is completely contracted against these stones. We don't see any anechoic collection of fluid because the stones have completely filled the gallbladder. And so this can be mistaken for bowel gas, but if you're having a patient that has classic symptoms of biliary colic or acute cholecystitis, and you see this, if you try to dislodge the gas here, you won't be able to do so. And you're also not going to see that kind of shiny, shimmery, hyperechoic kind of artifact that happens when there's gas. Instead, you're seeing posterior acoustic shadowing, which is associated with stones. And so this is the wall echo shadow sign, which can be seen in the gallbladder filled with gallbladder stones. Lastly, I want to go over emphysematous cholecystitis, which can occur whenever the gallbladder gets infected with gas-producing microbes. So your anaerobes and your clostridiums and things like that happen to produce lots of gas can actually start to fill the gallbladder with air, or at least produce enough air that it results in what looks like, once again, lung. And so this looks like bowel gas, it looks like lung, but it's occurring in the section of the abdomen that we associate with the gallbladder, and you often will be able to sort of change your probe angle and see the anechoic lumen, which is popping in right here at the end. And so this is a sign of infection and generally needs to be managed surgically with or without some antibiotics as well. And so emphysematous cholecystitis is pretty rare, but it's something that I've seen once or twice in my career thus far, and that you have to have a high diagnostic threshold to be able to see on ultrasound. So in review, we looked at our biliary exam technique and indications and reviewed the normal anatomy of the gallbladder. We talked about the quantitative assessment, including taking measurements of the gallbladder in the long and short axes, measuring the gallbladder wall and the common bile duct. We looked at some examples of the cholelithiasis, polyps, and sludge and how they appear on ultrasound. We talked about acute cholecystitis and what some of the ultrasonographic findings suggestive of acute cholecystitis might be on ultrasound. We took an example of the common bile duct and looked at how we could measure it and saw what it looked like when it was dilated. And then we briefly reviewed some artifacts and other findings that may or may not be present when scanning patients with biliary complaints. And that's a quick rundown of the biliary exam using point-of-care ultrasound.